Hey guys, so today on the Are We There Yet podcast, I am joined by cardiologist and heart expert Dr. Jim O'Brien from the Matter Private Network. Did you know that heart disease is the biggest killer of women in Ireland, accounting for 1 in 4 deaths? That is insane. And Jim talks to me about how our heart is affected during menopause and how sometimes too much exercise can actually be bad for our heart. Also, by the way, if you are watching this on YouTube, you will be able to see me doing 10 push-ups right here on the studio floor. I definitely wasn't expecting that. So anyway, sit back and enjoy my chat with Dr. Jim O'Brien. Jim, lovely to meet you, and you're very welcome to the Are We There Yet studio.
Kathryn, thanks a million for having me. Yeah, delighted to be here.
So let's get to know you a little bit. We've been chatting and chin-wagging just while we were getting the mic set up. So tell me about where you studied, coming through medicine, and why cardiology for you? Why did you feel that was the area you wanted to specialise in?
Very good. Yeah. Well, look, I guess first and foremost, I'm a bit of a piebald. My dad is from Cork. My mum is from America. I was actually born in Virginia myself. Been in Ireland since I was 5.
Wow.
But as we were talking about, I was kind of raised in just outside of Greystones in North Wicklow, and maybe not different to everybody, but maybe a bit unusually, you might think. Medicine was something I kind of fell into as opposed to actually chose to do. I was kind of aiming basically to please mom and dad to do just good enough in my leaving that I got science in UCD, but I actually did maybe overshot the mark and ended up getting medicine in UCD. So I studied there. And probably somewhere along the way, maybe 4th, 5th year, I noticed that chest medicine was something I had a particular interest in. I couldn't decide whether it was lungs or heart. Navigated that, and then after college did my internship in Waterford, spent a year in New Zealand, as I told you about.
Yeah.
And then after my medical training, I just realised, after doing a year of respiratory, I thought, yeah, cardiology is probably for me. So I kind of, after a year or two, I joined the scheme and became a consultant ultimately. Yeah.
So before medicine, you were also interested in dinosaurs and music. Is that still the case?
Very much so. Oh yeah, that never leaves you. Absolutely. I'm honestly hoping that when this all falls through, I'll still go back and be able to pursue my dream of being a lifelong paleontologist and discover a Gymosaurus at some stage in the future,
Do you still play the guitar?
Oh, very, very rarely, Yeah, the lads would come in, most of the boys would come in most days and just be slamming it so hard that I'd have to give up, and I was never really any good at it in the first place. Total amateur. I'm no Tom York, I'm afraid.
I loved the fact that we had Aslan, because we're recording in the studio here. We had Aslan in the studio next door, and that was the first. You literally arrived in to do a podcast and you walked straight into Aslan.
Yeah.
And got a little free sound check.
Oh, not just that, but I was just thinking, oh gosh, Paul, I think you might have picked the wrong guy for the next interview. He's like, that's Aslan, I'm Jim O'Brien, It's not really fair. But we were saying as well, we were looking at the guitar cases together and we were kind of going, gosh, man, this place really is trendy. I mean, do other people just like wheel in their own table tennis tables, or should I bring it, should I brought my cardiac arrest trolley from work? Sorry, I just came out of work.
Yes, we're all about props. We're all about props.
Exactly, good symbolism.
But come here. Okay, so it was cardiology for you, but you are now let me see, can I pronounce this word? Electrophysiologist?
Boom.
Yes.
That's actually, better pronounced than I can actually do it at this stage. Yeah.
So tell me the difference between a cardiologist and an electrophysiologist then.
Well, look, I suppose all electrophysiologists are cardiologists, but it's not the other way around, if you know what I mean. So you have to train in general cardiology, and then you develop your subspecialty interest off that. It ramifies, and you can do maybe cardiac imaging, which some of my colleagues do. You can do cardiac interventional procedures, so stenting.
Yeah.
And, you might have heard about people that have heart attacks. Structural heart disease, which would be valvular dysfunction, and implanting new valves, TAVIs, etc. And then cardiac electrics, which is my jam. I'm sorry to say, I'm literally as geeky as you might have guessed with the guitar and dinosaurs. So I loved Mario 1 growing up. I loved Independence Day. I still think that all the Star Wars miniseries are only going from strength to strength. So if you're into that kind of thing, if you have a gaming mentality, electrophysiology could be very much what you're interested in. So there's a lot of intellectual, but there's a lot of imagination goes with it as well. So I really love it.
So I'm right in saying it's the electric. So it's kind of getting getting the wires in, getting the electric modes in, getting all of that to get the heart pumping again. Whether that's in through the skin, in through the leg, in through.
Yeah, I mean, your heart as an organ is almost like a house. It has its plumbing, which is kind of the structural and valvular stuff, and coronary stuff that I was mentioning, and it has its electrics. It has its circuit boards and things as well. So all the electricity starts in the top right chamber of the heart. It's called the sinus node. And then it gets held up getting from the top chambers after they've beat in a thing called the AV node. Is a gatekeeper node, and then the electricity fires down from that through into the bottom chambers, which pump and beat blood around your entire body.
Okay.
That's kind of it.
And then, so when you're fitting something like a pacemaker into somebody, is that kind of like, that's kind of like full on gaming then? You're like
big time. 100%. Absolutely. Yeah. He's, you can make an androids out of people. So I'm joking. You don't really like, but the point is sometimes the heart's electricity can slow down a bit unexpectedly through no fault of the patients. And sometimes it causes hemodynamic compromise. People can faint unexpectedly. They can get bad chest pain walking because of chronotropic incompetence. They can't ramp their heart up to usual. And in situations like that, you have to implant a small battery, usually under the skin here by the left collarbone, with a couple of wires going down into the heart, connected to the battery. And if the heart tries to slow down below a certain reference number, you literally, it just gives little electrical impulses that the patient doesn't feel and speeds it back up to a respectable level again.
Okay. All right. So you are not doing big open heart surgeries. Mostly you are, as you said, working with the electric. So who are the types of people coming into your clinic? Like, is it everybody from teenagers to old ones?
Absolutely. It could be, it's all comers. So it's a massive expanse in honesty, Kathryn. You get teenagers and, even sort of there can be hormonal influences, if you like. So teenagers can come with quite a lot of palpitations. A common diagnosis electrically is something called an SVT, where electricity starts to run around the upper chambers of your heart like a washing machine. They be the teenagers. And then, as we were intimating, as you maybe move on a bit, as you pass the age of 70, 85, about 1% to 2% of the population can have slow electrics as well. So you might have to consult on them and maybe have to put a pacemaker in a 93, 94-year-old on occasion.
Okay.
So,
and when it comes to, say, just the kids and the teenagers, because we know that there's we're hearing a lot more about heightened levels of anxiety. So when you've got a teenager coming in with those palpitations, how is it very easy and kind of quick to decipher what's physical and then what's psychological?
There can be clues. There can definitely be clues. Now, you can never know for sure. Actually, we can probably talk a bit more about how wearables and the idea of wearables nowadays can be quite beneficial, because it might actually crack the code or sense a diagnosis that you otherwise might not get with just a 10-second ECG at an office setting when they don't have their palpitations. So if you're a young teenager, maybe a 20-something-year-old that's getting intermittent sort of big single bumps of the heart, or little flutters, as they often describe them, it's usually quite a benign process and it wouldn't have you worry. But sometimes people describe things where they get the heart coming on literally like a switch being flicked. And then suddenly the heart is going stuck at exactly one rate, maybe 200 beats a minute for 5 minutes for no apparent reason at all. And then if it stops just as rapidly, and it can often actually happen if the patient takes a deep breath, yawns, takes a glass of water, that might be a bit more indicative of an SVT, which actually does come with some treatment options,
Okay. And then when you're talking about older people, because we're going to get on to women in a minute, but when it comes to older people, so we know that, well, actually, let's go with women, right? Because we know that heart disease in women is the number one killer of women in Ireland. I did not know that until very recently.
Both, absolutely, yeah. And women, they're actually, my colleague, Dr. Roisin Colleran, I'm not sure if you've ever heard, she did a brilliant summit on women's cardiac health earlier this year. And one excellent phrase that she came up with was like, women are not just little men. So all of the trial data dating back, I'm sorry to say, was fairly misogynistic in that it focused mainly on men's symptoms.
And that's not just with heart health, that is with medical health, that is with across the board.
100%, absolutely agree.
It has been women's health has been so under-researched and so underfunded.
It's
and
terrible.
So that doesn't surprise me at all.
No, and there's certain hormonal phases that women have to go through that men don't experience in the same way. So women are much, much more likely to experience palpitations than men. Actually, nearly kind of a summary would be maybe the plumbing side of things, the coronary stuff often kind of pertains to men, and the electric side, palpitations, etc., would be a lot more kind of the remit of women nowadays. So like there's a few things, some of the legitimate diagnoses that I'd be used to seeing are palpitations, which can definitely have a hormonal influence. So it can be, like for instance, atrial fibrillation. You might have heard of that. So that's a disordered heart rhythm that comes from the upper chambers in the heart. It usually is kind of more of a function of age, but people at any age can actually be at risk of getting it. So if women have irregular menstrual phases, so if it comes late, if it comes early, if it happens very sporadically or infrequently, they're about 1.5 times more likely to get atrial fibrillation.
Wow.
That's one thing. There's very, very poor data describing whether or not perimenopausal women, where, their hormones have adjusted, with their stage in life, if they're more likely to get atrial fibrillation. Some data sets say not, but they're a lot more likely to get palpitations in general because of the hormonal imbalances, maybe some of the HRT treatments that they take.
And is that specifically to do with estrogen levels?
Often, yeah. Okay. It's just, more than anything, it's just the variability versus what they were used to historically. Like, I even met a lovely woman in the emergency department last week, is actually taking testosterone supplements as well as estrogen replacement, which is done sometimes in the perimenopausal phase. And she's doubled over with a terrible surging heart rate in the middle of the night for no apparent reason, which thankfully is all completely benign. But just, it's just a good indicator. Just at that stage of life, it's just a bit more preponderant. It's very tough, like 16% of all like primary care visits are to do with palpitations, and atrial fibrillation can be associated with about like just less than 1% of all emergency department visits, and 70% of them usually need admission if atrial fibrillation is actually diagnosed. I feel like women get a terribly raw deal with it a lot of the time. And look, we'd like to try and provide a service where, it's not in your head first, because that's another thing. Atrial fibrillation, so there's about 35% crossover of depressive symptoms and anxiety symptoms in people that have atrial fibrillation. And women, at certain phases of their menstrual cycle, a lot of the time, or even the perimenopausal phase, will often kind of be afflicted by the same symptoms and might be tempted to say, oh, listen, this is just my time of life, or I'm just feeling a bit anxious
or
and
whatever.
I shouldn't get this checked out.
Yeah.
And like, there's some trial data. I think there was a trial called Remedial, where people that actually were confirmed to be depressed with atrial fibrillation and just got a simple ablation to treat it, like, it improved their depression as well.
Wow.
Yeah, they got better. So, and women a lot of the time are afflicted by, kind of all of the surroundings of that too.
And going back to the lady who was taking testosterone tablets and who was taking her HRT as well, what was the outcome there? Was it due to one or the other that was causing the...
It's hard to say. It's actually hard to say for a fact. There did seem to be a little bit of a relationship, if you like, between when the HRT was started earlier in the year and even when the testosterone supplement was added in. I think it can be beneficial just for libido. I think at certain stages of life in those instances, it did seem to kind of corroborate with when with her symptoms
first started. So does she have to come off all that then when she presented to you?
I actually don't think so. In her case, we did an overnight monitor, like a 24-hour tape of her heart rhythm. Yeah. Maybe if anything else, just to give her peace of mind to know that this wasn't actually like a dangerous diagnosis or a threat to her. And thankfully, it came back completely normal. So I felt, and she was getting a bit of benefit in that her exercise regime was a bit better. Maybe some of the depressive symptoms, like went with the anxiety symptoms, the sleeplessness wasn't nearly as difficult to deal with. So we kind of came to the conclusion that maybe she's better served just remaining on it. Once we've proved that even with her symptoms present, it just translated to a normal sinus tachycardia and wasn't of any particular danger to her. So
yeah, we're hearing all the time, Jim, about the benefits of estrogen when it comes to HRT for perimenopausal and menopausal women. Obviously, everybody is different and individual, and we've got to say that, and it's under the guidance of your doctor. But we're hearing the benefits of estrogen in, for example, osteoporosis. Is there any research or data specifically related to estrogen and women's heart health?
I'm not enormously sure. I actually, for what it's worth, knowing this podcast was coming up, I had a quick look on the internet the other day. The data was pretty scanty. There were a few maybe meta-analyses that failed to show an exact relationship between hormonal replacement in perimenopausal women and protection against arrhythmias. I guess as a non-interventional cardiologist, I wouldn't be able to tell you for a fact what its contribution might be in terms of cholesterol management or the risk for coronary disease in some of the other divisions of cardiology. But the signals do seem to suggest that with the right combination, as long as it's not exacerbating any nasty palpitations or chest symptoms you might be feeling, it seems to have some benefit.
Okay. Can we talk about heart disease for a moment, and the fact that how heart disease differs in men and women, and how heart issues would present differently between men and women as well. I know you touched on it, but just let's go back to that if you don't mind.
Yeah, as we were mentioning a while ago, most of the original data sets surrounding risk of coronary disease, heart attacks, benefits of stenting, benefits of bypass, they were all geared towards men and your classic anginal sounding chest pain related to heart attacks. Or, I think we've all even know people, it's usually a man in his mid 50s to 60s, sort of peri-retirement, sniper's alley, that state of nature when men lose their purpose in life, they just keel over and have a heart attack and die. They your classic weight-like sort of elephant sitting on your chest with associated pouring sweat, breathlessness, a pounding feeling of your heart, that sense of impending doom. Women get a little bit of a short straw, and that's primarily not the way they'd present. A lot of them would feel kind of a pre-syncopal, like they're about to collapse. With no warning, or maybe just breathlessness of unknown cause, and people get breathlessness for nothing, and maybe some palpitations, maybe a bit of dizziness. It's a bit indistinct with women, and therefore they're less likely to seek out medical help and present. So, in terms of gearing up towards women's health, it's challenging, from that regard when the symptoms are a bit unclear, and we don't actually have legitimate data sets to kind of dating back to time out of mind to identify and treat those people in a timely manner.
But what I'm getting from you is that if you're a woman in her mid 40s, perimenopausal, 50s, 60s, if there's those feelings of anxiety, don't be just fobbed off by
definitely
your
not.
doctor because that can be one of the primary symptoms.
Definitely not. Yeah. Well, there's great data that supports atrial fibrillation is a disordered heartbeat from the upper chambers of the heart. That's not an insignificant diagnosis. It affects about a quarter of the Irish population. About 5% more than 60, about 10% more than 80 all have it. And it can have a very strong relationship with the risk of stroke, which is, the worst possible thing that can ever happen to an adult human being. So it's 5 times more likely to happen in atrial fibrillation. Women and men present with atrial fibrillation for completely different, even neurohumoral reasons. So that's how nerve endings supplying the heart tend to trigger atrial fibrillation. So you can get so-called sympathetic, so fight or flight hormones, your adrenaline surges. And they're dependent on certain L-type calcium channels in your heart that tend to trigger ectopy, so extra heartbeats. And after depolarizations, where electricity just starts again for no apparent reason, that can trigger these sort of cascade effects where atrial fibrillation comes on. That's more likely to be women. And then there's the parasympathetic, so that's a slowing influence of your heartbeat by another set of nerves, your vagus nerve primarily, where what that does is that it actually, through potassium channels, without going into too much detail, it tends to cause a dispersion of repolarization. So how your heart's electricity bleeds through the cells comes in different manners in surrounding cell types. And with that spatial dispersion, it causes these things like re-entry, so little rotors of electrical misfiring that sort of fan out in all direction, almost like a pinwheel. And they're actually more likely to affect young men that are very, very fit, that keep active, that tend to have a slowed, influenced heartbeat for the most part, or even, your holiday heart, if you like. The lad that goes out on a weekend, they get a big sympathetic overdrive, and that's why they can't sleep the first few days. And then a couple of days later, the vagus nerve said, we better slow the heart back down again. And it slows it down too much, overcompensates, and it actually triggers the holiday heart AFib. That's men and women, just in atrial fibrillation alone.
Wow.
So there's striking differences, depending on your gender.
Wow. Oh my God. Listen, our hearts are working 24/7, right? So if you do ever feel that worry, maybe some unexpected chest pains, palpitations, breathlessness, you need to know that there is also expert help available 24/7 too. That's why I want to talk about Mater Private Network in Dublin. They are the only private hospital in Ireland offering urgent cardiac care all day, every day. And I'm talking weekends, bank holidays, even in the middle of the night. Now that is genuine peace of mind. This is such a unique service for anybody who is worried about their heart. And if you're not sure, just pick up the phone and call them first. You can ring 1800 24/7 999. you'll be put directly through to a cardiac specialist nurse who will talk you through your symptoms. If they need you to come in, you'll get a thorough assessment immediately. If you need treatment or a procedure the same day, they'll arrange it straight away. It's about getting swift, expert care from one of Ireland's leading hospitals. If you're worried about your heart, the number to save is 1800 247 999. For more information, you can log on to matterprivate.ie. Save the number and be prepared. Well, let's keep focusing on women and talk about protection. I mean, we all know the diet, the exercise. We'll talk about wearables in a little bit. And we've talked about symptoms and what to look out for. But for women specifically, when it comes to cholesterol, let's talk about cholesterol, because it's one that we hear all the time. And I think in a lot of cases, we don't fully understand good cholesterol, bad cholesterol, what the cholesterol should be.
Yeah.
So give us the rundown on that for women.
Yeah. Well, look, I mea culpa, but I'm very amateurish sort of knowledge. It dates back to my college lectures, but I do know that your general total cholesterol target should be in the domain of just under 5. And there's a low density lipoprotein, so the so-called bad cholesterol, and another one will be triglycerides. You'd be targeting somewhere in the ballpark of less than 1.7 for that. And I tend to be a bit of a how would you say? I look through a fairly broad lens. You only get 20 minutes in an office consultation with a patient. They're asking you about cholesterol. I usually use the Michael Pollan credo from his book. It's eat food, not too much, mostly plants. So when you think about it,
I like that. Eat food, not too much, mostly plants.
Yeah, and as you can see, it's a nice broad brushstroke. It kind of covers you in all angles. So you're avoiding rice, potatoes, cereal, pasta, porridge, all carbohydrate, sort of starchy and stodgy foods. You'd be avoiding all the, maybe the red meats. That's pretty heavy going stuff. The sugary foods, the high fat diets, all of them tend to kind of turn to sugar, which turns to fat and kind of starts to deposit in your coronary arteries. So usually, something like that, if you're kind of adhering to that as much as humanly possible on a day-to-day basis, you're doing well.
Well, I just, while you were chatting there, I took out my recent cholesterol check. So my total cholesterol, 5.61. My LDL cholesterol, 2.9. That's high. My HDL cholesterol, 2.37. So break that down for me.
I'll prophylactically call the coroner for you. I'm not sure. See the day out, No, it's fine. I mean, most of the time, the LDL, the one is it 2.6?
2.9.
2.9, okay.
Yeah.
Most of the time, that actually can be managed with a carefully curated diet, much like I said, So as long as you're eating mostly fruit, vegetables, beans, pulses, lentils, salads.
Which I am. And this is what I found interesting. I eat a huge amount of fruit and veg. My mom has high cholesterol as well, so I don't know which is the genetic one.
Yeah, the triglycerides can definitely run kind of a family deep. Or what did your ones come up there?
Oh, sorry, my triglycerides is in the desirable range, 0.38.
Oh, grand. All right.
Okay.
Well, even the LDL can
definitely
it can run familial sometimes. All right. So that much is not your fault. I'd say you're doing everything right, Kathryn.
Well, okay, but how do I get my LDL cholesterol from 2.9 down to the desirable? What did you say it was?
1.7 or less. I guess that'll be up to you. Yeah, the red alcohol can contribute. Yeah, maybe the butter. I didn't want to have to say it. Yeah, but exactly. Yeah, the butter can definitely add up salty stuff. The O'Donnell's crisps. Ugh. I grudgingly have to admit, as an O'Donnell's crisp fan myself, that maybe if you didn't need a bag every day, it might be for the best. But it sounds like you're doing nothing wrong for the most part. Sometimes you just have to accept. What you could do next is sometimes what you can do is you can look for secondary evidence that there might be some of your arteries might be at risk in future. So what we do in our hospital is we offer to do maybe a CT, coronary angiogram. So it's just a CT scan looking for plaque burden in your coronaries that might have deposited over time. And if there's, the evangelical or puritanical among us might see any plaque at all in your coronaries, you might be as well to start going on the statin a bit earlier in life. Just drive that LDL down as low as you possibly can. And it's interesting because it's a bit of a moving target. There's people with LDLs less than 1.7 that still have loads of coronary plaque, So we don't really know all there is to know yet. The statin is literally just like, it's like a prophylactic measure. If you have a drain and you never wanted to get lime scale in it, just pour a bit of Mr. Muscle down every day.
So that's the protective. So even on low levels like that, you could still be talking to somebody about going on a statin.
Yeah. Okay. We've done, honestly, we've patients for no apparent reason at all that have perfectly normal cholesterol of 4, an LDL of 1.5, and have a big, massive clot-laden heart attack, they go on statin to just continue to drive that number down as far as absolutely possible, you know?
And why do women see their bad LDL cholesterol spike 25% during perimenopause, even if their diet hasn't changed that much?
Excellent question. I don't understand that much myself, but I do know that some of the hormones, you know, in the perimenopausal phase definitely have a bit of an influence on the tendency to, you know, sort of aggregate and deposit cholesterols in the vessels. And I have to just assume that they just, it's just a bit more likely related to that.
And again, I know not your area of specialty, but should cardiologists and gynecologists be working more closely together? That's kind of what I'm thinking.
I think that would be a very, very worthy program.
When women are going through that stage of life of menopause and perimenopause, and hormones govern everything.
You're absolutely right. I mean, in a way, as you said, you know, the cholesterol influence starts to become a bit more preponderant as, you know, the hormonal imbalances causes it to add up. There'd be a huge benefit, I think, to having a regular kind of a combined, a multidisciplinary meeting team where you're looking at the patient's palpitations, maybe the symptomatology related to the hormonal imbalances, the anxiety and depression that might go with it, all the while keeping an eye on their cholesterol and making sure they're not at risk of any major cardiovascular endpoints.
Okay, so we've talked diet. Let's talk exercise. Is there a thing that too much exercise is bad for you?
Oh no, don't ever say that. We're a funny old race, really, aren't we? There's, you know, addictive and obsessive personalities. Doesn't matter what decade you're in. And back in the day, you know, it was nicotine, alcohol, you know, really instant gratification, dopamine release. Nowadays, it's kind of slow gratification. I don't know, maybe since the smoking ban, you know, in pubs. Actually, even my own father-in-law, who's down in South Kilkenny, even thinks that pubs themselves might be a thing of the past in about 30 years' time. Do you know, everybody's online now talking to each other. Nobody has to go down to a local speakeasy. Maybe an added benefit is nobody becomes an alcoholic now. So people are finding new ways of channeling that same obsessive energy, and exercise is actually one of them. And it's a funny one, particularly in my line of work in heart electrics, AFib risk. It's actually a U-shaped relationship. So the ultra sedentary, so the people that take way less than 3 hours per week exercise, but you know, quite perversely, the ultra fit, so the people that are in the habit of doing regular ultrathons, Ironmans, you know, regular marathon runs, they're actually much more likely to get atrial fibrillation as well. Some of it actually seems to relate to your heart rate variability. Okay, I understand you enjoy your fitness yourself. You know a bit about that.
Yeah.
So there was a trial called MESA recently that looked at that and found that the extremes of heart rate variability, so the ones that have no heart rate variability at all, so the bottom 10%, and then the ones that have the maximum heart rate variability over a given day, so the upper 10% are most likely to get atrial fibrillation. I guess the bottom 10, you can understand, they're so sedentary, they don't ramp their heart rate in any meaningful way at all. But the upper one is they're challenging it a bit too hard. I mean, the heart is a muscle just like anything else. You might have even heard about this phenomenon called athlete's heart.
Yes.
Like, here, just as a demonstration, jump down and give me 20 push-ups.
Me? No.
Just go ahead. Yeah. 20 push-ups, yeah. Thanks. Or 10, whatever you can do, Kat. So just note to the audience here, Kathryn has easily just done 10 push-ups. So my theory is not working. Kathryn is too fit. Well done, Kat. So my point would be, now jump down and do another 20. So there you go. So there you go. So that's kind of like your pec muscles giving you feedback to kind of just to tell you to feck off, or to tell me to feck off. And in exactly the same way, your heart is a muscle as well. Now, it beats millions of times in your life and never asks anything in return. It's the most amazing organ, you know. It needs for very little, but you can overtax it the same as anything else.
Yeah.
And the athlete's heart is a reflection of that. So your heart literally starts to atrophy and scar over, given patches of scar. Your chambers of your heart dilate. Actually, even a good reflection of the risk of atrial fibrillation is ascertained by how big your heart is. So they studied whales before and harpooned whales like minke whales, and the whales that they pulled up found that they were in atrial fibrillation because their heart is so enormous.
Big.
It has a massive substrate to generate atrial fibrillation, and the heart in humans is no exception. So huge heart rate variability can actually trigger it as well.
Yeah. So
like the WHO has a set of criteria. I think they talk about 150 minutes a week, so it's about 2.5 hours divided in sort of 20 to 40 minute aliquots. And if you do it maybe 4 or 5 times a week, you're fairly gravy. But if you do anything more than moderately high intensity, then the protective cardiovascular risk, which keeps you at a low risk, starts to lose its momentum, and it starts to come back up, making you at risk again.
Runners, the Spencer Matthews, the 30 marathons in 30 days, that's kind of a red flag.
It can happen. It can happen. Yeah. Look, the only thing is, you don't want to discourage people for doing the right thing.
Yes, of course.
You're doing the right thing, folks. Don't ever listen to Jim O'Brien. Do not hang your hat on today's talk. But sometimes the ultra fit, if they do have an MRI of their heart that confirms myocarditis and is felt to be an athlete's heart, or if they are in and out of atrial fibrillation, or get a lot of ectopy reflecting the tendency to get atrial fibrillation or dangerous or more dangerous heart rhythm disturbance, we try and, we go into negotiations basically about maybe a slightly phased reduction of what their exercise might be. Like, I had a really interesting girl, the nicest person you've ever met, such a nice lady, 42, 43 years old. She loves it. Absolutely loves it. And you wouldn't blame her, right? I mean,
loves exercise.
Yeah, loves it so much. It's her safe space.
Yeah.
Gets her away from the kids, so she's not going completely mad. She gets good sleep as a consequence. But
is she an ultra exerciser or a regular exerciser?
Has done. Yeah. Okay. So now my theory with her is that she's exercised so much historically that she's actually given so much parasympathetic, remember the vagal influence, slowing her resting heart rate down so much that it seems to be the dominant force in her heart now, and it has actually slowed her sinus node, the one that starts your pacemaker activity in your whole heart, has slowed down to the point that she can no longer ramp her heart rate up on demand in exercise. And actually got a pacemaker a few years ago, which unluckily came to some harm. So it kind of actually transited all the way through her heart muscle and started pacing her phrenic nerve. So she started getting hiccups as a consequence of her pacemaker when she was out exercising. And then she got some pericarditis as well because it had exited her heart and was tickling her pericardium, which can be very sore. So she needed the whole shooting match out. So she got that done. And then I was, my negotiation with her that was this week. So
she had kept the whole pacemaker out.
Yeah, we had to reef the whole lot out. And that actually nearly is a surgical procedure. So that's a very, very high risk procedure. It comes with a significant, not inconsiderable mortality rate. And the next stage that she'd love from me is to get what these new devices that we're doing nowadays called leadless pacemakers. So instead of a device with leads that go down from the heart up near your collarbone, what you do, obviously, because one in her case came to harm before, what you do is you deliver an entire, maybe pen head sized little bullet from the top of the leg. The entire generator and leads are in one small contained hermetically sealed device. You actually payload that into the inside of the heart and just rest it there and leave it there so that any previous leads can no longer, exit the heart, causing phrenic stimulation or pericardial irritation, and hopefully ramp her heart rate up on demand. And they have very little crafty little algorithms as part of them that kind of maybe, let's say, see what your the impedance across your chest is doing, into suggesting, oh gosh, Kathryn's breathing harder. I'd better increase the heart rate to keep up with her. Wow. So if you're doing that, it's kind of like a surrogate to indicate you might be exercising, and you might ramp up the heart rate to a sensor indicated rate. That's the next thing she'd like from me. However, I'm sorry, it's been a long talk.
No.
It's like, some of me would love to just introduce the idea of a phased reduction of her exercise. She's got it to the point maybe of a sort of an obsession, which I don't really blame because it's so good for her. But in this case, there could be an argument, as opposed to putting her through yet another really, really, really risky procedure with a leadless pacemaker. Maybe if we just reduced her exercise without omitting it entirely, she might be absolutely fine, and her sinus node might bubble back to life over the next few weeks and months,
But she wasn't very receptive to that.
At the moment, we're still on a leadless. But it's, we're living in a cool a la carte world where there's new technologies, and it's justified. It definitely seems to be guideline indicated in her case, and she's a young lady. It means that she meets the guidelines and criteria for a leadless pacemaker when a previous one has come to harm. So at no stage is this in any way a finger pointing exercise or a blame game, but it's just interesting to know that exercise can have both good and bad effects for people's hearts and electrics.
And most of us kind of sit in the regular exercise space. For those women and men listening who want to up their exercise, and I would have seen this a lot on Operation Transformation, people who would have gone from a very sedentary lifestyle to then introducing an exercise program. particularly for their heart health and specifically for their heart health. And there was always this thing of women feeling very anxious and petrified when they got out of breath when they were running.
Yeah.
And that's something that's kind of, it's kind of like a heart anxiety or health anxiety piece, but it's something that I hear a lot from my own female friends as well. If they're just trying to start an exercise program, that they have this fear when their heart starts beating really fast.
Yeah.
And I'm kind of just going, that's just your heart working.
Yeah.
You know, but it's a big
You're
thing
right.
for women.
It can be unclear. And as we talked about a while ago, you know, the way women present with genuine, legitimate cardiovascular health problems can be a bit different to men, can be hard to interpret. Paul and I think, actually had a chat about this even last week. Do listen to your body. Like it you know, for billions of years now, we've kind of evolved into who we are in order that your physiology is kind of usually dictating to you when enough is enough. And, you know, if you find on day one that you're breathless or have a surging heartbeat at a certain stage of your exercise, it's okay to stop there. You know, you probably know more about this than me, in honesty, Kathryn. You know, how to get from the couch to your 5K or, you know, the transformation stuff that you did brilliant series on before. It doesn't happen overnight.
No.
It is okay to push your boundaries, but you know, sometimes the use of these wearables, and I guess this would be a great way to introduce this topic, can be of some benefit to those people that actually do have some health anxiety, not too entirely sure, could this be a genuine heart issue or something? The wearable can be a very, very legitimate way of finding that out, because it's actually very, very, you know, it's great fidelity technology. Like, so most of the publications nowadays, Smart Wars from a couple of years ago, so in newer publications are saying that smart technologies with ECG capabilities that you can wear in your watch, maybe you have one. I actually don't wear one.
I don't wear one. I was looking at your wrist.
No, I don't. Yeah,
I don't wear a wearable,
I stay away from it because I'd become obsessed.
I've actually done so many of these interviews now, and through this podcast of the benefits of wearables. My whole thing was, I wanted to innately know from my physio. I know what I need to do to work my body, and I don't want a wearable telling me, because I just think innately if you listen to your body, you will understand. But the benefits of wearing these actually are becoming so much more clear now for people who are starting off. For people, and as I went to get a VO2 max test done there recently, and he was saying you can push yourself more.
And
if you had a watch that told you that, you know, so I was comfortably going, but I've been doing the same thing I've probably been doing for 10 years. And as a 47-year-old woman now, if I want to increase my fitness, I'm going to have to push myself that little bit further. And his argument was a watch or a wearable can give you, it's metric based.
It's great, actually. Like, I mean, you probably read that. Is it Erickson wrote the book about the personality profiles and, you know, the kind of, I don't know, the leaders and then the supporters. And I'm sorry to say, I'm a horrible green supporter. I just want everyone to run around holding hands all the time. And then you got the enthusiasts, but you got the data-driven types as well. Yeah. And it's very, like, these type of people are totally fine. Like, I mean, sometimes they can't tell, is their physiology telling them they're having a serious problem or not? And if they love their data, a wearable might be of some benefit for that, to say, no, it's okay. This is sinus tachycardia. And then, you know, your target heart rate, as Paul and I mentioned last week, you know, kind of travels with you over time. So it's the number 220 minus your age multiplied by 0.8 or 80% of that number. And that's actually
explain that now to me again. Sorry.
Well, if you think about it, like if you are 21, like you take 220 and so your target heart rate would be 200, wouldn't it? Ish.
Yeah.
So you get 80% of that number.
Yeah.
That would be a reasonable target for you to reach 20 to 30 minutes at a time in the 4 or 5 times a week that the WHO recommends.
Get you.
So if you've got, and actually it can be quite, you know, discouraging, I'd say, that's coming from never having been fit before. Let's say if they're doing a transformation thing like this, they might find themselves reaching that target heart rate way too early in their exercise, and they might think there's something wrong, but it doesn't happen like that. You just need to get physically capacitated and vagal influence, all that kind of stuff. So that's absolutely fine. You just allow for it over time. So you do day one. If you get to 80%, that's fine. Stop and go, yes, I got to what I needed. You know, it was better than doing nothing. That was a credo I adopted back in college because I wasn't great at studying. I was like, just do something, Jim. It's better than doing nothing. So that might be a good way of thinking about it for the early weeks when you're just starting from zero, you know? So you get to 80% that first day. Then you do it again 2 days later and you find, oh gosh, I got 400 meters further according to my watch, and it's fine. my wearable, my iWatch is saying I was still just sinus tachycardia, got to 80% again. And slowly but surely you just start moving your way forward until hopefully you reach that steady state, you know? And consistency is kind of key from then on, like even in terms of AFib prevention, like so in people that have weight management issues, you know, just a fairly common cardiovascular risk factor. You know, it can translate to sleep apnea, which can be another risk factor for AFib in my case. So weight, if you can keep your weight down by 10%, if you're in the obese or morbidly obese category to begin with, it gives you a 600% less likelihood chance of getting atrial fibrillation in future. So I think a wearable would be totally fine for some of those guys, you know, absolutely fine. Of course, it can be obsessive as well.
Yeah. And I mean,
that's why I don't.
That's why you don't wear it. Because are you an obsessive personality type?
Yeah. Actually, I remember that when my friend and I were like going interrailing when we were like 18, the Swedes used to take pictures with me because they're like, I'm an Irish guy that doesn't drink. But like,
Do you not drink?
I don't drink.
And never did?
Never did, Kat. Okay. I don't know what is wrong with me. The rest of my family do. They're all fine. But I guess that, you know, there's a bit of alcohol dependence on both sides of my family. So maybe it's a bullet that I'm happy to have dodged, you know, the kind of way.
How bad is alcohol for our hearts?
Very. Interestingly, there was a heart summit that I did a talk on a couple of weeks ago, though, where there's kind of data and very large data sets that says any drink above 0 per day that you take sort of incrementally and just like linearly just continues to increase your chance of developing atrial fibrillation, but not in women. Women get a curvy linear relationship and your first drink comes, if anything, it actually nearly drops you down in terms of a risk for atrial fibrillation for that first drink. So I'll give you a glass of Prosecco immediately after this.
So just if you have just the one.
Just the one.
Just the one.
Anything above that and it starts to rise again. Yeah. So girls, 1 drink a day is totally fine, you know? The same applies to coffee. Actually, 1 coffee a day apparently is fine.
Yes, because the caffeine, being over caffeinated is something that we're hearing and reading a lot more about as well, on how it impacts our hearts.
Yeah.
Can you talk to us about that?
Yeah, too much coffee is bad. Okay. I'm sorry to say that I'd be fairly living proof of that. For instance, I didn't sleep a wink last night.
You were talking to a breakfast
I was worried about
presenter.
Meeting up with my hero, Kathryn Thomas, and I had too many coffees, and now I'm rambling like an imbecile, you know. But too many coffees is bad for you, definitely. It can trigger atrial fibrillation. Do you remember I talked about the sympathetically driven atrial fibrillation, the one with fight or flight?
Yeah.
Coffee does all of that. So it can trigger all the ectopy, it can trigger all the after depolarizations that can trigger atrial fibrillation. It's bad for cardiovascular health. But interestingly, there's a journal article released this year in Heart Rhythm as well, which is a very prestigious journal I read all the time, you know, right alongside with Now Magazine. I actually have Now Magazine open just on the inside of Heart Rhythm, you know. And I got most of my medical education from The Simpsons, as you can probably guess, you know. But anyway, in people that were serial caffeine drinkers that get atrial fibrillation and get a cardioversion done, the people that abstain completely are actually more likely to get AFib back than the people that just go back to kind of sort of moderated, just 1 coffee a day by comparison. Okay. Yeah.
Wow. So what is too much coffee? Are you talking 3, 4, 5, 6 cups? Yeah.
And I'm sorry. Yeah. Like I make up. I'm as guilty as anyone of all of that. It's 21st century living. So yeah, anything more than usually 2 can be a bit of a risk factor, I'd say.
Okay.
General rule.
What upcoming technology is exciting you most? I know, from the technology space, we're talking wearables, but specifically for heart health, and is there stuff coming down the line that you're very excited about with AI and the impact that AI is having on healthcare as well?
Yeah, AI is starting to prove amazing. There's big data now that AI is can predict incident atrial fibrillation in certain risk factor people, or even if you just put a 12-lead ECG and it looks like the top chamber of your heart, the way it natively beats on something called the P wave. It's the first deflection on your ECG. It can tell from that whether or not you're likely to get atrial fibrillation over a certain time space. So I'd be very interested to see what that holds. And, you know, I'm an ablationist as well. So I'm in my own way, I'm an interventional cardiologist. I'm delighted to say in electrophysiology particularly, we are in a sunburst of brand new technology types. So ablation, you know, most atrial fibrillation comes from 4 veins in the top left chamber of your heart, the left atrium. They're called the pulmonary veins. Just the point where the vein meets the heart muscle tissue can be the place where heart muscle cells get stretched, which tend to misfire electrically, causing atrial fibrillation comes on. So if you do an ablation, which means burning away the insides of the offensive parts of people's hearts, usually burn around those veins. Originally, we used to use thermal energies. So that was either heated tip probe, and you just, slowly but surely do a little dot by dot caterpillar around the insides of those veins until they're isolated. Or cryo, which is where you use a frozen balloon and actually just freeze those heart myocyte cells to death. But there's a newer technology called pulse field ablation. And it's a genius idea. It's you basically apply a really, really high frequency, low amplitude sort of voltage to the inside of people's heart, which for all intents and purposes just shakes the heart muscle cells and tells them to switch on their natural apoptotic or cell death pathways. But what's great about the PFA, the pulse field ablation, is that it tends to be sparing to other tissue types in the vicinity.
Wow.
So your esophagus, your food pipe's right behind your heart. You do not want to ablate that because that can cause an atrioesophageal fistula, which can be fatal. PFA does not injure esophageal muscle with the voltage field that is selective just for heart myocyte cells. It doesn't hurt other nearby nerve endings, capillary beds, all other tissue types. It doesn't cause the same collateral damage as before. And there are single shot devices that where you literally just put it in to the vein, you open it up into kind of a flower or a hand shape, and you just push the on button. So it's kind of, like that Simpsons episode, The Idiot Proof Air Force, where Bart climbs into the cockpit and it's like, go, stop. So even Jim O'Brien is able to do these kinds of ablation, kind of way. So it's
exciting.
It really enhances procedural efficiencies and procedural safety in equal measure, and patients are coming back with really good outcomes.
Yeah, I mean, that's the whole thing. When everyone is giving out about AI and it taking over the world, when you start reading about AI in the medical world and how beneficial it's going to be and how it's game changing for surgeons, for patients when it comes to patient autonomy as well, helping the patient understand if you're going in for a surgery or if you're going in for an ablation, actually what is, what's actually involved in the treatment and the process. And I think that's where AI is going to be hugely beneficial and continue to be. Yeah.
The thing about AI though, just like maybe a cautionary note, is that it's going to give you a probabilistic chance of what you're going to go, like, is it Hitchhiker's Guide?
Hitchhiker's Guide to the Galaxy,
Yeah. It's like, what's the answer to, what's the meaning of life? 42. How'd you come to that conclusion? Doesn't know. AI is like that.
Yeah.
It's an integration of all of the data sets in the world, but it doesn't know how it reached that.
Yeah.
So it gives you a probability that you might, but it won't be able to definitively tell you why it reached that conclusion. So do use it, but just maybe be just be advised as well. Whether it happens the other way to the way that the AI predicted, maybe don't be too discouraged as well. So anyway.
Well, Jim, the podcast is called Are We There Yet? When it comes to the heart electrics, we're not there yet. There's plenty more still to come in terms of technology.
Infinitely.
Yeah.
Oh, we are so far from being there yet, But it's a really exciting environment. Like, I count my blessings every day that I was waiting for a bus, and next thing somebody gave me a medical degree, and they let me turn loose on all this excellent technology, and it really. I know it's a really, really drippy and sentimental thing to say, but for my gaming mentality notwithstanding and playing video games inside people's hearts, it really matters when you get to play like level 7 in Mario Brothers inside of somebody's heart. And at the end of it, not only do you defeat Bowser, but the patient is left smiling at you in bed much better as a consequence many weeks later. A happy patient and a happy family. That really, really matters to me. I was like I said, I fell into medicine accidentally. College was always kind of hard for me because I was angsty. I wanted to play King Crimson on the guitar. I didn't know what I was doing. I didn't know if I wanted to become a doctor until I qualified from medical school. And you actually watch, maybe the applied science of what you learned in college actually translating into meaningful endings for patients is really, really good.
Yeah. I have to say, I love your attitude. I love the fact that you are very self-deprecating. But
my wife will explain to you justifiably. That's what some of my patients, in fact. But anyway,
but you are saving people's lives. I mean, and the fact that you can do it with a smile and do it with, and an excitement in terms of the technology that's coming down the line. But it's a great position to be in. It's a great place to be in, as you said.
I really do count my blessings. And, it's a really, really great hospital to work with, an excellent group, having the subspecialty divisions. We're the biggest group in Ireland in cardiology. So, if God, there's something to do with this person's coronaries. I don't know anything about that. It might be a column. Can you help me? It's there's a great sort of interdigitating, relationship amongst all the colleagues there as well. So it remains a really, really exciting place to be.
For the ladies listening, give me 5 tips for good heart health that we should all be going away with today.
Eat well. Don't ignore your symptoms. Do honestly seek out medical help if you've any concerns that something might be wrong. I guess the sniper's alley for you guys, different to men at retirement age, might be the perimenopausal phase. That would, of course, be a time to get yourself checked if you've concerns about your heart health. And there are loads of structures in place to look after you. How many was that?
That was 4. Have 1 drink a day.
And have a drink a day, please. Yeah. Enjoy a nice glass of red
don't
wine.
Smoke.
And do not smoke. Yeah. Smoking equals bad, in summary.
Jim, thank you so much for coming into us today.
Glad to be here. Thanks a million, Kathryn.
Listen, our hearts are working 24/7, right? So if you do ever feel that worry, maybe some unexpected chest pains, palpitations, breathlessness, you need to know that there is also expert help available 24/7 too. That's why I want to talk about Matter Private Network in Dublin. They are the only private hospital in Ireland offering urgent cardiac care all day, every day. And I'm talking weekends, bank holidays, even in the middle of the night. And that is genuine peace of mind. This is such a unique service for anybody who is worried about their heart. And if you're not sure, just pick up the phone and call them first. You can ring 1800 24/7 999. You'll be put directly through to a cardiac specialist nurse who will talk you through your symptoms. If they need you to come in, you'll get a thorough assessment immediately. If you need treatment or a procedure the same day, they'll arrange it straight away. It's about getting swift expert care from one of Ireland's leading hospitals. If you're worried about your heart, the number to save is 1800 24/7 999. For more information, you can log on to matterprivate.ie. Save the number and be prepared. You've been listening to Are We There Yet? Hosted by me, Kathryn Thomas. Visual design and video edit by Stephen King O'Farrell and Connor Daly. Music courtesy of Audio Network. Series producer Paul McGregor and executive producer Sasha Hamrogue. New episodes of Are We There Yet? Are released every Tuesday morning wherever you get your podcasts, and you can also watch this episode along on YouTube. Are We There Yet? With Kathryn Thomas is an Onic original.